A very good evening to all of you, and I welcome you all to yet another interesting session of 4D detailed discussion and dialogue for Indian diabetics. So, today we have a very important complication of diabetes that we'll be discussing. So, to discuss on this important topic, that is diabetes and foot complications, we have with us a young and dynamic endocrinologist from Kolkata, Dr. Amitabh Sur. He's a senior consultant endocrinologist at Department of Endocrinology and Diabetology, Peerless Hospital, and BK Roy Research Center, Kolkata. He's a member of the American Association of Clinical Endocrinologists, American Diabetes Association, Endocrine Society, and Endocrine Society of India. He's a reviewer and author of numerous publications in various journals and also in textbook chapters on endocrinology. He has won many prizes, in fact, a very good endocrinologist and a very good friend, in fact. So, over to you, Dr. Amitabh. A warm welcome. We're all waiting to listen to you on this important topic of diabetes and food complications.
Thank you, madam, and thank you for giving me this platform. So, food complications are one of the most important complications which we see in our patients of diabetes. Both type 1 and type 2 diabetes can develop this complication. If we talk about type 2 diabetes, roughly around 40% of all the patients who are living with type 2 diabetes develop foot ulcer at some or other point in their life. The importance of foot ulcer is such that if you see the prognosis of foot ulcer overall, that means life expectancy of a person who is living with diabetes once he develops foot ulcer is at the end of 10 years, after 10 years of developing a foot ulcer, only 25% of people who develop foot ulcer actually survive. So, prognostically speaking, foot ulcers are even worse when you compare it with cardiovascular complications, which we discuss more often. Foot ulcers in type 2 diabetes can be because of neuropathy, neuropathic foot ulcer. It can be ischemic foot ulcer. It can be a combination of both, that is neuroischemic foot ulcer. Both component can be present together. So we will be discussing in the subsequent during the subsequent course of the presentation about each one of them and how they are different to each other. How do we classify foot ulcers? What are the precautions which our patients should take to prevent development of foot ulcer? And also we'll be briefly discussing about treatment of foot ulcer. By and large, what steps we should take once a person develops foot ulcer. Diabetes and foot complication. So I'll be starting my presentation. So prevalence of diabetes, we all know, as per the recent ICMR India study, roughly 1 in 9 adults are living with diabetes in our country. The figure of patients, absolute number, we don't know, but the estimate is around 9 crores people who are living with diabetes in India. And if you can take into account the prevalence of foot ulcers, you can very well guess that crores of people develop foot ulcer in their lifetime, during the course of their lifetime in our country. As I said, foot ulcers can be because of neuropathy, it can be because of vasculopathy. Neuropathic foot ulcers usually develop on plantar aspect of the foot. Ischemic foot ulcers develop generally at the peripheral end of the limbs. The neuroischemic foot ulcers can develop on the medial or the lateral aspect of the foot. Now, once a person develops foot ulcer, the person is at risk of developing sepsis overall and limb amputation. Diabetic neuropathy often leads to development of diabetic foot ulcers. Up to one-third of diabetic patients may suffer from diabetic foot ulcers. Global prevalence of diabetic foot ulcer is in the range of around 1.6 to 8%. Recurrence rate of diabetic foot ulcer is also very high. Once a person develops foot ulcer, chance of developing a repeat foot ulcer is up to 40% at the end of 1 year and up to 65% at the end of 3 years. Now, classification of foot ulcer is very important for prognosis purpose and also for communication between us doctors, because foot ulcer is a team effort. Whenever if I want to convey, I've seen a patient of foot ulcer, if I want to convey to my colleague that what is the status of the patient, I want to document what is the position of the foot ulcer at the present moment, and I want to objectively see that during the course of treatment how much it has kind of healed, then the only option remains is appropriate classification of the foot ulcer. Now, the commonly used grading system which we use in our clinical practice is the Texas grading system. In the Texas grading system, we use a grade, we label it as grade 0, 1, 2, and 3. Grade 0 is when the patient is having pre-ulcer, that is, maybe the patient is having callus or the ulcer has already healed. That means there is no breach of skin. Grade 1 is when there is a superficial ulcer with no penetration of the skin. Grade 2 is when there is a penetration up to tendon and capsule but not involving bone. And grade 3 is when the bones are involved. Apart from that, we use classification in each grade is divided into A, B, and C. A and D, of course. A is when the patient is not having any infection or ischemia. B is when the patient is having infection but not ischemia. Grade C is when the patient is having ischemia but not infection, and D is both infection and ischemia. So this is how we classify ulcer. Whenever we are seeing an ulcer, we label it as maybe Texas grade 2A or 2B or 2, like that. We have to label it so that we can prognostify the ulcer. Now, as I said, pathophysiology of ulcers composed of three components mainly: neuropathy, peripheral arterial disease, and other aligned factors. Other aligned factor means type 2. For healing of the ulcer, what we need to take care is patient's glucose profile should be in absolutely desirable range. Controlling the hyperglycemia is of pivotal importance when we are trying to treat the foot ulcer. But apart from hyperglycemia, we also have to check for whether the patient is having anemia or not, whether the patient is having dyslipidemia or not, whether the patient is having hypertension or not. So these four components should also be addressed. Apart from that, neuropathy plays a very important role in foot ulcer development. Sensory neuropathy leads to loss of protective sensation, and that leads to formation of deformity in foot, and that increases the risk of developing foot ulcer. Motor neuropathy also adds to development of deformity, and that also again propagate development of foot ulcer. Autonomic neuropathy leads to dry skin, no sweating, etc., and that compromises with healing of the foot ulcer. Now, to address this neuropathy component, the most important part when we treat the foot ulcer is immobilization, particularly for the neuropathic ulcers. It is more valid for neuropathic and neuroischemic ulcers, more so for the neuropathic ulcers, because neuropathic ulcers are mainly on the plantar aspect of the sole, where it is kind of a dependent position. Pressure will never allow the ulcer to heal. So while treating ulcer, we need to take care that there is complete immobilization of the ulcer bed. That can best be achieved with total contact cast, but this is not required always for all patients. Many times, customized footwear can also help us in achieving desired level of immobilization if the ulcer is depending on the ulcer size and shape. Peripheral arterial disease is also something which we need to address. Peripheral arterial disease, diabetes particularly affect the microvasculatures, and this peripheral arterial circulation compromise leads to development of ulcer and ensures non-healing of ulcer. So therefore, while treating ulcer, we have to check for vascularity, and we have to use agents which can improve, although it is very difficult, but still antiplatelets and all are used very commonly. Revascularization is also sometimes required with the help of CTVS surgeon. Vascularization status is also important to decide the level of amputation, because healing of the amputation stump also depend on the ulcer, on the level of vascularity. Now, ulcer vascularity assessment, if you check using CT angio for the vascularity, that is one of the best way. But then CT angio is not always possible, so at least arterial Doppler study should be done each of our patients. So now therapeutic strategies, as I said, now if glycemic control is most important. So in glycemic control, in achieving glycemic control, of course, agents like DPP-4 inhibitor, SGLT2 inhibitors, and GLP-1 analog play a pivotal role. One important point which I missed in the previous slide, because it was not present part of the slide, is customized footwear. Like what are the situations, that's a very common question we encounter from our patient also, where what are the situation where customized footwear is required. So customized footwear is required in situations when the patient has any previous history of foot ulcer or patient is having any foot deformity. These are the two situations where customized footwear is almost always required to achieve desired level of immobilization. So SGLT2 and DPP4 mechanism, all of you know, I will not go in detail. They have been achieving good glycemic control and that help in treating foot ulcer. Nowadays, we have come up with some new data from China. I don't know how much reliable it is, but anyway, wound healing is promoted with DPP4 inhibitors. But anyway, DPP4 inhibitors remain core treatment of type 2 diabetes to achieve good glycemic control.
Thank you, Dr. Amitabh, for pointing out the very relevant aspects of diabetic foot ulcers. What is the pathophysiology of diabetic foot ulcers? And most importantly, the importance of offloading of the foot, which you emphasized, which is often forgotten, in fact, especially when it comes to neuropathic ulcers. So, we'll have a few questions. So, what do you think are the risk factors for foot ulcers, especially when it comes to Indian setting?
Most important risk factor for foot ulcer is diabetic neuropathy, particularly sensory and motor neuropathy. Sensory neuropathy will lead to inadvertent injuries in the foot about which the patient will not get aware. And patient usually don't look, particularly in the plantar aspect of foot daily. A small ulcer can gradually become large. Motor neuropathy will lead to formation of claw toe, other deformities, and that deformities actually, lead to irregular pressure distribution, and ultimately that also lead to foot ulcer development. Callus formation happens because of the sensory motor neuropathy, and that is actually a pre-ulcer. Ischemic diabetic vasculopathy is also an important risk factor for developing foot ulcer because of impairment of the microcirculation. Even if any ulcer develops, a small ulcer develops, there is improper healing, and that leads to development of foot ulcer. Poor glucose control can also be labeled as one of the causes of foot ulcer, as aligned causes of foot ulcer, that can also be said to be one of them. Apart from that, patients are having foot deformity already for some reason, maybe sensory motor neuropathy. In our country, they hardly wear customized footwear for those who actually require it. So that is also one reason they will keep on wearing that footwear which is not meant for them. So footwear related ulcers, particularly seen on the dorsal aspect of the foot, is also a common reason. So that is also footwear related injuries are also common causes of foot ulcer.
And I think barefoot walking is also quite prevalent in our
Yeah,
country. Probably one of the other risk factors.
particularly at religious sites, maybe.
Yes, yes, yes. So, how do you screen for these diabetic patients for foot issues, and how frequently should you screen?
So we should examine the feet of patient at each visit appropriate. Actually, ideally speaking, it doesn't take much time. It should take hardly around 2-3 minutes of our extra time. Inspection only will help us in looking at the foot, will also help in discovering many problems, because inspection only will help us in knowing that whether the patient is having any small foot ulcer or not uncorrected, or any callus or not, or any deformity or not. So if the patient is having callus removal has to be said, deformity, then customized footwear has to be said, any small ulcer has to be treated like that. Apart from that, if we do palpation, we have to see the arterial pulses, particularly at least with hand, we can see dorsalis pedis and posterior tibial artery pulse. This is very easy to see whether the pulse is palpable or not. Although this doesn't ensure that microcirculation is intact, but still, at least we can have 2 out of 1 palpable is also okay. Circulation is more or less okay if 2 out of 1 out of posterior tibial and dorsalis pedis. Then we should also check with tuning fork for loss of vibration sensation and monofilament. I agree that in busy practice it is difficult, at least difficult for me, what I have realized. But then if we have someone in our clinic, not me as such, but some person who can help me, then monofilament test is very easy to do. Loss of protective sensation, LOPS. This is a very important term. If LOPS is there, foot has to be taken care of very rigorously, but probably customized footwear is also required for them if monofilament test is impaired, but may not be if there is no deformity. But at least patient has to be very conscious that they always have to wear footwear if there is LOPS.
Okay, well said. So, from this, we understand that it's not only the physician, but the patient also has to be educated about foot care. So, can you tell us how would you educate your patient when it comes to foot care
What
in
I say,
diabetes?
madam, is to each of my patient that you should wash your feet daily, clean your feet daily with soap and water. This helps in two way. First, the feet is clean daily, and secondly, they daily examine the feet, because while cleaning they have to examine, and after cleaning they have to dry it properly, including the finger web spaces, toe spaces, sorry. And then after that they need to apply some moisturizer. It can be Vaseline, coconut oil, anything, so that the feet are relatively wet, they are not dry. This is important because if the patient is having autonomic neuropathy, this dry feet also can add to the foot ulcer risk, and moreover if there is already ulcer, that can increase in size. So this is what I say. And I also ask them to trim their nail properly, identify what is ingrowing of nail. If they have ingrowing of nail, I ask them, please don't do it on your own, come to hospital, ask a surgeon to do it, or a podiatrist at least available. And once a year I ask for VPT and monofilament test. So should be done ideally every time, but that is always not possible. But VPT, to we do it once a year for each patient. VPT and ABI, we do it once. I don't know whether it's ideal or not, but we do it once in a year.
Yeah, but most important, I think, would be the self-examination practice, so that the patient himself or herself identifies, and with the foot mirror, with the mirror under the foot, and just to examine if there are any calluses or any ulcerations which are just starting off, so they can seek medical help earlier, so that at least we can intervene early and prevent loss of foot or limb, in fact. So you've talked about the Doppler that you want to do for your patients. So, are there any other imaging modalities, any evolving imaging modalities when it comes to diabetic foot ulcers?
Yeah, ABI is what we routinely see, but when ABI is impaired, suppose the cutoffs are both ways more than the normal range, above or below the normal range, then we ask the patient to do a formal arterial Doppler study. And if there is a loss of biphasic flow, loss of triphasic flow in the arterial Doppler study, then potential for revascularization has to be assessed, and then ideal investigation is CT angiography. But we do not say it for each and every patient. That has to be decided by the CTBA surgeon, who will actually do the revascularization, that whether it is required or not. We usually don't ask. We, after the arterial Doppler is impaired, we refer the patient to the CTBA surgeon to take call.
So, whenever we talk about diabetes, we always talk about the diet. So, is there any role of micronutrients or antioxidants or any special nutrition plans that you would advise your patients to prevent diabetic foot ulcers?
To prevent foot ulcer, I'm not aware of, but yes, if the patient is having foot ulcer, then adequate amount of protein intake which is allowed for that patient as per his or her EGFR and ACR situation वगैरह, is something which is of important, because adequate protein intake will help in healing of the foot ulcer. But to prevent, I'm not aware.
So, how important is glycemic control, and what sort of HbA1c targets are we looking at?
Glycemic control is very important for foot ulcer, although it is not the only point which matters. But once the foot ulcer is developed, we have to keep the glucose in the proper ADA recommended target. Not aware of the ADA recommended A1C target for foot ulcer management, but should be 7% ideally. But fasting plasma glucose and postprandial plasma glucose should be in the target range. Fasting plasma glucose should be in between 80 and 130, and postprandial glucose value should be less than 180, even if the A1C is more. Many times patient will have high A1C because they are carrying the sins of someone else, but at least the fasting and PP has to be controlled. That has to be ensured by us.
So when we see patients with diabetic foot ulcers, it's just not only diabetic foot ulcer, because they could be having other comorbidities. They could be having end-stage renal disease or maybe post-renal transplant. They could be on immunosuppression. So they could be having other comorbidities as well. So in these very specific situations, how will you navigate these foot ulcers?
So CKD is one of the risk factors for developing foot ulcer, and also CKD is established risk factor for non-healing of foot ulcer. So if CKD is there, it becomes a problematic situation. We have to manage the CKD as per the protocol which we use for chronic kidney disease management, and There is, I don't think, a separate protocol for foot ulcer treatment if the patient is having CKD. But yes, there is a prognostic importance that if the patient is having CKD, maybe we have to be more aggressive, particularly for, suppose if my patient is having CKD and the patient is also having plantar aspect foot ulcer, maybe in the forefoot or in the hindfoot. So it becomes more likely for me to advise him TCC. I don't know, for if the patient is also having CKD, then probably maybe I would have seen with some other modes of immobilization, because I know that this patient is having CKD, so it will become more difficult for him to heal from this foot ulcer. So the ultimate aggressiveness should be there for management of those who are having CKD.
Thank you, Dr. Amitabh, for sharing your wisdom and experience with us about diabetic foot ulcers. So, we have had a fairly good discussion today on this very important complication of diabetes. We have delved on the importance of preventing diabetic foot ulcers and how to manage foot ulcers. So, hope you all enjoyed this discussion as much as I did. So, thank you once again.